Okay, so here's a new case. I'm just going to review. This is actually for someone else that has requested for me to do a workup. So I'm doing this case, and I'm going to record it so that he can get some feedback on it, but also hopefully help some others as well. All right, so this is an ortho case. So this is when I first opened a Blue Sky Plan. I'm going to click on orthodontics, and I'm going to click on import models, and I'm going to locate these files. All right, so here's the upper model. Look around, see what we've got to work with here. So in this model, I just paused the video because you can see all this stuff on the outside of these teeth. I'm not sure which scanner was used to make these models, but this is problematic. We can't have this on there. Some scanners will clean this up automatically if you get enough data around it, the actual tooth and tissue, but this left it. So I don't know if it was because of insufficient data for it to know to remove it, or if it was the software just doesn't do that. I'm not sure. So anyway, I opened it up in Mesh Mixer and cleaned that up a little bit. Got rid of that. I mean, there's nothing I can do about the missing surface out here. That's just wasn't there in the scan, and it is likely why it's there in this. So if you look from the underside, you can see that it's missing. So again, can't really fake that. I can guess, but it's kind of pointless. It is a third molar, so we're going to work and manage our way around it. We've got the first and second molars well captured, and the third molars. I will say that I'll just throw this out there now. Make sure that we get trays that cover the mesial if we can, as much as we can, so at least something keeps those from super erupting, because we don't want those to super erupt and have those that be the only teeth in occlusion. The one other thing I want to comment about these models is right here is this incisal edge discrepancy. And so you can see that essentially the facial aspect and the lingual and incisal aren't connected properly. So there's a slight discrepancy, and it goes over to here. And you can see this roughness on the model of the canine. And if you can almost tell that the margin is here and then it drops in, which means that the facial is below the lingual. That's just going to make the trays here in this area not fit quite right. Technically, the whole arch is slightly skewed, and the doc that sent this to me, I had it cleared with him, and it'll work. It's just going to be, he's going to have to be prepared that they're probably not going to fit quite right in the anterior. Like there's going to be a little bit of a space here. So he's up for moving forward. He might have to do a refinement or whatever. But that's up to him. So. All right, so I'm going to go ahead and click OK to bring this model in, and let the software load. I'm going to call this the maxilla, and I'm going to go ahead and import the opposing. Here's the lower. Nothing, well, of note here except for this bleb. So I'm going to go ahead and delete this right quick. I'm going to go open this up in Mesh Mixer. So I think this software just doesn't delete this stuff very well. I've never run a model like this through Blue Sky Plan. I don't know if it would automatically delete this for me. I know I can in the model editing phase, but that's in the surgical guide software. So I'm going to go ahead and just pause for a second. All right, so I've now created a new model, and here it is. I literally just opened this up in Mesh Mixer, deleted that spot, and moved on. I don't care about any of the other stuff. I think I can work with just about everything else. There are areas that it would be nice if this tissue hadn't lapped over the buccal surface of this, because I don't think that's just where the patient is. I think this is the cheek hitting it, because the gingival margin is too abruptly vertical here. So I'm pretty sure a little more time scanning this would be nice. Same thing with right back here. But again, these are third molars. We'll manage. Okay, so I'm going to click OK. And so now the software has all the models in. And this patient is pretty clearly class 2. So make sure you know that ahead of time and you discuss that with the patient. I may start their class 1 on the left side. And then they're half step plus class 2 on the right. They're going to have a midline discrepancy, and things aren't going to correct completely unless if you want to, that's fine. You can work on elastics and whatnot to try to correct that. But if not, make sure you tell the patient, because ideally we're going to bring these front teeth forward, get them in a line, which is actually going to increase the overjet. So although they have a little bit different, but they have a pretty deep bite and a little bit of an overjet, but they're going to have a more of one if we actually properly align these teeth. So again, it's just one of those things we need to make sure we identify during treatment planning and case assessment and discuss that with the patient so they know what to expect. All right, so I'm just going to go ahead and call this patient, geez, I don't know, Jane Doe. I don't know this patient's name, and I don't really want to. All right, click forward to do alignment, and so this is pretty straightforward. Just going to click on the teeth. I'm going to hold the shift button, click, mesial and distal. The more accurate we are here, the better the software knows where the true mesial and distal teeth are. I'm going to make sure that we track out to the buccal cusps. And since we actually marked wisdom teeth, it automatically advanced to the other side of the mouth for us. All right, so that's all marked, and we can see it lines up everything there. Now let's go to close model. In the past, we would want to clean it up, trim it up and everything, but we don't need to do that anymore. We'll just go ahead and close it. It's going to be ugly for now, but that'll be addressed in just a little bit. Okay, so it looks a little crooked, but that's really just because there's a cant. This canine's, this whole side of the mouth is slightly intruded, yeah, this, for what I need, this will work. And now let's do the same with the mandible. This dot got a little bit wonky. There we go, just drag and move it. Okay, finish marking, close model. All right. All right, and here's our closed model. I like to check just to make sure I have enough virtual stone below the teeth, and I do. So, all right, continue to teeth segmentation. This part can take a little while for the computer to process. I'm recording, and every time I'm recording, my computer runs a little bit slower just because everything is capturing. All right, it's done. And that was real time. I'm not going to fast forward this in the recording. I could, but honestly, this is a case review, and so I'll let you guys decide if you want to just fast forward while viewing. And notice I just merged those two dots to bring the embrasure a little bit lower. And you can't do it that way. I haven't even tried that before. I was curious if I could. And there we go. This little guy doesn't really matter too much because we're not going to move it, but we do want to make sure that it is segmented, because if we don't, the software treats tissue or anything that's not segmented as tissue, and it inflates it. So I'm going to draw a line here. There we go. A little better separation there in the papilla. Everywhere else is looking pretty darn good. Right here, that's my way of sort of adding some nodes to separate a little better. That looks good. right here. Looks good. And it always takes some refinement, even though, I mean, this is, if for those that have used this before, this software is incredibly accurate now by comparison. And these single line segmentations are awesome because it really makes making the incisal embrasures much more predictable. Okay, so let's go ahead and continue the mandible. So let's fix this guy right there. And oops, Control Z whenever possible. There we go. And we'll combine these because all right, that looks a little better. Sorry, I'm gonna. There we go. Looking pretty good. I'm being pretty picky, but it's also not my case, and so I'm going to be a little extra picky with someone else's case because I want as predictable as possible for their outcome. I probably wouldn't go through this much detail otherwise. All right, there we go. Now we're going to model trimming. And the software is going to use these lines to figure out where it should put this auto trim line. And then we're going to augment it. We're going to change it a little bit to get exactly the way we want it. But this is a huge step forward because now we don't have to do all that trimming. So between the auto segmentation and these auto trim lines are probably the two biggest features I'm happiest about with all this. For this part, I actually am going to pause the video. Never mind. That was actually pretty quick. I thought I was going to go check my email. All right, so I'm going to bring these lines up here a little bit, get them nice and a nice smooth surface. Everywhere's pretty good. I'm more or less bringing it to the point where I would trim my aligner trays or just below that. Anything below where you're going to have your aligner trays just doesn't matter. So that's just my kind of thought process or how I think about that. And I do like to look down here and see if I can create sort of a flat heel from on both sides so that when I export these models or when I add a print platform for these models, I've got a flattish, whatever surface to align it to. It's going to be hard with this tooth, that's fine, but alright, I think we'll just manage and just a little bit more with that. Alright, let's go to trim. Okay, sorry, I dazed out for a second. Let's go to the mandible, and let's get this off of this excess material that we just don't care about. And There you go. All right. All right. Let's move this. Good enough. All right, so I think we're good. Nice smooth models, well segmented teeth. All right, I had to pause it for a second there. Anyway, so here we are. We are at the alignment phase now here. So the question is, which do you want to align first? I don't think it really matters in this case because it's going to have class 2. So over jet, you're not going to be worried about interfering with, as you align the upper teeth. So I'm just going to go ahead and get the upper done first. I don't know what all, the patient is looking to correct, honestly, in this case. I should probably follow up before I finalize this design. But what I'm going to do is, most of the cases we're not moving molars, posterior teeth, if we can avoid it. Selectively, if we need, teeth are really malpositioned, whatever. And you could argue that this premolar can be rotated. So I guess, sure, I'll go ahead and do that, Problem is this tooth's been in this position for so long, honestly the contacts won't be as stable if you do that. So I don't know that it's really makes sense to do it, but whatever. If you want to straighten it out, whatever, then great. But yeah, I'm going to lock that. I'm going to leave that alone. That was just a quick little adjustment. The rest of them, I don't see much need to fix them, except actually we may have to level them out. So for now, I'm going to leave them from a rotational standpoint, and I'm going to bring these curves out to what I think they need to look like to give a nice symmetric arch. Okay, and you'll notice that I put this right in the distal, this premolar, distal is premolar. It's different for each case, but I'm trying to keep it symmetric across the arch. Because if I keep them the same width, same distance anterior posterior, it makes this overall shape uniform. And so now I can hit snap all teeth, everything else is aligned, and there we go. So now it's created massive diastemas because I created too much space, which is fine. That's just kind of where I'm going to start, and I'm going to start working my way back a bit and walk this line back. And snap all teeth, and there. Now we've got diastemas. You've got contact down here, which is the software thinks it's contact because the way the teeth were initially, and it doesn't, it had to estimate where they were. So there just wasn't data down there. So I'm going to ignore that, and I'm going to say, yeah, there's definitely a diastema. So I'm going to bring this back a little bit more. Snap all teeth. And I'm cinching that back. Now, once you get it pretty well straightened out and you want to cinch it back even more, I will tend to actually bring this down, this line, and now hit snap all teeth. I don't have to move any nodes, and it just starts to cinch things together. I'm going to go ahead and go back up a little bit, snap all teeth. Snap all teeth. Okay, so I'm at 0.1 everywhere, and well, a couple of 0.15s, but that's fine. And then what I'm going to do is I'm going to take these two teeth and I'm going to tip them forward or together a little bit, essentially getting rid of the diastema and the IPR, and I'm going to allow the plastics to sort of stretch a little bit, because I want very positive contacts. I do not want to run the risk of having open contacts in a case like this. So that's it. IPR wise, I'm good. Again, ignore this 0.25. You're not going to do IPR there. There's no real contact. That's in the gingival area where basically the papilla was interpreted as tissue of tooth because they couldn't help it. We didn't give it enough data. So that is where imaging is really important. Right down here is a little bit of embrasure space. So that's that. I'm going to turn off the IPR because I'm pretty satisfied with that. I'm going to click on a different tooth, one of these teeth that I've locked. That's why they're gray, and they have a little lock identifier on them. And I'm going to look and say, okay, well, we've talked about this patient has a bit of a cant, and do we want to address it? How can we address it? I will tell you that completely correcting this cant is going to be tough because it appears to me that this canine is intruded, and so is the lateral. Now, if the canine was fine, the lateral wasn't, we could extrude it. We can even extrude these premolars, but trying to get the canine, basically the premolars, all the way from lateral to second premolar all extruded is going to be difficult without some cross-arch elastic or inter-arch elastics, so elastics down to the bottom or TADs. So I'm going to leave it like this for now, and I'm going to talk to the doc that I mentioned it with. Just know, or that I'm working on this for, just know that here's what I would do, is I would bring this one down, and you can use the grid function right here to line things up, or I can just use the line. I'm so used to using this snap to curve line. But if you want to use the grid, you can just come like here, grab this tooth, bring it down, unlock this tooth, and this one. All right. And since we did those vertical adjustments, we are going to have some I'm going to turn off the grid, sorry. We are going to have some IPR changes potentially. Not really. But they are going outward, which means I'm going to tip it back in. The outward is just because they are, that's just where the roots are. They're kind of flared out a little bit. So now that I've done that, I'm going to push it back in a little bit. That's relative intrusion extrusion. As I tipped it in, because it was flared out buccally, it sort of appeared as though it was extruding. Okay, so now let's go ahead and, yeah, I think we're pretty good there. I would be happy with this setup if I can accomplish that. Again, that's going to require most likely that we have some like a button on this canine and probably this guy as well, and just pull it down apically. Now it'd be most ideal if you had a TAD in the lower so that you could use the elastic down to the TAD, because then you know it's fixed. It's not going to move on you, and you're not relying on just the opposing dentition to hold it. Bring this one down just a little bit more too. Okay. And a lot of times when you do this extrusion now in the lower, we're going to have to do intrusion. So that's again why the TAD can be helpful, because we can intrude the lower and extrude the upper concurrently. Okay, so we've got the upper pretty well aligned. You can turn off the IPR, click on a hidden tooth or a locked tooth, and you can see where we started and where we ended up. It's really not that significant, but I mean, it makes a big difference in the smile, that's for sure. So let's go ahead and look at the mandible now. And first of all, let's go ahead and straighten things out. And again, I'm going to lock the posterior teeth. Just based on the kind of alignment I did in the upper posterior, there wasn't a lot other than some small rotations. And I don't see any severely rotated posterior teeth. I need to align these a little better, but I'm going to go ahead and work with what I've got for now. You know, I guess, yeah, I'm going to see how the upper occludes against. Let's take a look. Do we, yeah, we need to tip this tooth in. So let's go ahead and unlock that one. All right. And now I'm going to go ahead and click snap all teeth. I tucked it in a little bit, straighten these all out, and they look pretty darn good to me. IPR wise, I mean, you're going to have these little diastemas or dark triangles, but that's just based on where their teeth initially were. If I click on reset all teeth, you can see that, you know, they just have a long contact, and that's just where the papilla is. You're going to, if you're going to align that, you're going to end up like that. So if you want, you can IPR those contacts flat, drop this down a little bit, snap all teeth, or sorry, wrong direction. Go up with it a little bit, snap all teeth, and you'll get some IPR that'll, you know, afford you some room. But I'm not going to do that unless the doc I'm working with wants me to, because we have that overjet already that I don't really want to make worse if he doesn't want me to. So what am I seeing here? Now we extruded these teeth, so that's obviously going to cause some impact, and it's going to impact the other side. And I can see that right here on this canine, this premolar, possibly that premolar. I would assume so, at least. And so I can also turn on the collisions as well, and it will calculate how things collide, and you can see those high points. And let's turn off the IPR. Click on yeah. Let's even hide the curve. We don't need that right now. And so I'm going to work on intruding these, because this canine's hitting high too, and all these, this whole interior is super erupted. You can either try to intrude here or extrude the posterior, but digitally, I'm going to go ahead and grab this guy, intrude it a little bit. Now it's going to recalculate the collisions. Used to be much slower. It does it pretty quickly now. I tend to just turn off the collisions and then just turn it back on when I'm done with this. So in a case like this, I'm going to be honest, I'm going to put buttons on almost every single tooth, because I want them to be very locked into these trays and move in mass. All of them move together. And one way to do that is to put buttons, because I also want, if one of them is going to not track, I want all the rest of them to move sort of the opposite direction, meaning it might require that as we are trying to intrude these teeth, these will extrude a little bit. And that's pretty common in bite leveling cases in orthodontics. That's very common, I should say. All right, I think we're looking pretty good. And let me show opposing arch. I'm going to turn that off. Click on a back tooth here, and I think these look pretty nice. I'm going to go ahead and intrude this a little bit more. I'm going to turn off those collisions. I'm not doing it for that reason. I'm doing it just to level the incisal plane. Okay. So now I'm all done with alignment. The issue, or the next step, is going to be to assess the movement sequence. For me, I'm going to go ahead and click on biweekly as opposed to monthly or weekly, and now I'm going to click on continue to edit steps. And this is where the software is going to determine how many steps it takes. The lower, it's done in 11 steps, 11 being the final. It's the intrusion that really takes that does a lot of the work. And so everything looks pretty good. I don't like the contact between the two central incisors. They're colliding as they're trying to align, and that's because number 24 is staying here while it rotates instead of getting over here where it's got empty room and some space to work with. So I'm going to tell it to get over here sooner by clicking on the tooth, tipping it to the distal until it's well out of the way. Click refresh steps. Sometimes it'll add a step or two because it has to, but there we go. It avoided the collision much more significantly. So I just had to redirect that tooth a little bit. That looks good. I'll go ahead and save my work. Should have done that a while ago. Just a second. Okay, so let's go ahead and move up to the upper and see how this looks. This one's got more, and it doesn't surprise me, especially with the extrusion. And I'm going to see how it looks from the occlusal first. Doesn't seem to have any IPR like big. Oh, sorry, I have turned it off. And we're getting some significant IPR here, but we also knew we were going to, so I might delay this tooth a little bit. Also, that canine is rubbing on the distal there. Now, again, I'm not actually that worried about it because I think it'll just deflect to the mesial, but I'm going to try to correct that just to show you how to correct it. That and the other central is the only other concern. So first thing I'm going to do, because the central is hitting this tooth prematurely and it's done moving so early, all I'm going to do is I'm just going to tell it, okay, hold up. Oh, sorry, plus there's space on the back of it, big old diastema being created. So instead, I'm just going to tell it to hold up, wait till step 3. Don't move until step 3. You see that? It just delays that. Everything else moves out of the way a little bit sooner. And it really, when it says step 2, it's instead of step 1. So it's just waiting 2 trays for that one to start moving. And then this one, because it collides on the distal there, I'm going to grab it right there, right before that, and I'm going to tip it to the mesial. Click refresh steps. And there we go. No collision. Nothing of note, at least. And that's it. All right. So that's it for this setup. I'm not going to move forward to adding buttons or anything to this. I can kind of, because I'm going to send it back to the guy that has asked me to do this, and before I add the buttons. But okay, so but just as a little note, let's take a look at where I would place buttons. So first of all, we need to extrude these teeth. Okay. Again, we can just try and rely on the central incisor and molar and all these other teeth to help to pull these teeth down, and it might work. It really might. But so in that case, I'm going to put a horizontal rectangle here, horizontal rectangle here, horizontal rectangle here, horizontal rectangle here, so that I have something to grab onto to pull down with. Now, again, it would be nice to have an elastic button right here, possibly there, that's below the tray where the tray is kind of cut out, and to have something pull for the opposing arch. But truth be told, the more I'm thinking about it, when you have a tray, you get to engage all the teeth, and so these 3 teeth back here, this entire side, all the way to the central, might be able to oppose and help to pull those teeth down. You're just going to get a little bit of under treatment because the plastic is going to deflect a little bit, so it's not going to fully erupt that much, but I think we could probably get most of it. So again, horizontal rectangle here, 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 here. Then I would probably also add a second button on this tooth, more vertical up here, to help because it needs to rotate mesially. I'm not going to put any buttons on these teeth. I just don't need them because of the way the directions are moving. This one, I'd put a vertical rectangle to help it rotate because it is a canine. It's a big round tooth. I want something big and flat for the tray to press on. So that's where I'd put the buttons on this one. On the mandible, let's turn off the IPR, show the initial position. And for these, I've got a lot of intrusion. So I'm going to put a horizontal rectangle, probably even on the second molars, but certainly the first molars, for certainly both premolars and canines and then canines back to molars. I'm going to go to second molars. Second molars all the way to canines, horizontal rectangles. I know that might seem like overkill, but leveling the bite is a lot of work. And then I'm going to put a vertical rectangle on this guy. You might not need it, but just because it is a fair amount of rotation. And that looks to be it. I did forget one thing. Let's go up here for a second. We rotated this premolar, as I recall. We end up, yeah. I'm not gonna worry about. Yeah, we already have a horizontal button. Well, we had a horizontal button on. Yeah, we had a horizontal button. So anyway, sorry. That's it. All right. Hopefully this video helps.